First of all, I would like to thank Dr. Srini for giving us this chance. So I will be cystic macular edema. So mainly two diseases, that is diabetic CME and CME in retinal vein occlusions. Other vascular conditions include CREO, MACTEL or vascular tumors or hypertensive retinopathy. So pathophysiology of diabetic CME is that there is a breakdown of blood-retinal barrier, loss of pericytes, hyperglycemia, oxidative stress, release of inflammatory mediators. All these results in the fluid leakage and CME. So diabetic CME, that is the most common cause for CME. Around 55% of CME is due to diabetes. How you can differentiate from other types of CME is that you may be seeing associated signs like microaneurysms, hard exudates, epiretinal membranes, vitreomacular tractions and all. The importance of cystoid edema is that the size and location of cyst influence the visual prognosis, so it becomes an important biomarker. Now let us see how this CME acts as biomarker. So the size of cyst, that is larger cyst and location, outer nuclear location indicate poor visual prognosis because there is already photoreceptor damage and more of macular ischemia. So you can divide cyst into small, large and giant depending on the size. And the bridging retinal processes between the cysts actually indicate a good visual prognosis. And one more classification based on different studies that the ratio of central macular thickness and the cyst indicate the visual prognosis. So if the cysts are occupying more than 90% of central macular thickness, that is a poor prognosis. We call as type 4 disease. And along with that, you have to assess the integrity of outer retinal layers. That is the external limiting membrane and the ISOs. If both are disrupted, it is grade D disease. If there is no disruption, it's a grade A disease. So all these are based on different studies. So in this example, you can see the last one is 4D. That is, the cyst is occupying more than 90% of central macular thickness, and also there is disruption of the external limiting membrane and the ISOs. So that indicates a poor prognosis. So cystoid macular edema acts as an important biomarker in diabetic macular edema. Now, what is the OCTA findings? Both the cyst and ischemic retina appears as non-perfused black areas, but the cysts are more blacker, but the ischemic retina is more of greyish in color. And also the vessel density in the superficial and deep capillary plexus plays an important role in prognosis. Both are reduced in diabetic patients, but the superficial capillary plexus changes indicate more of macular edema, while the deep changes indicate more of progression of diabetic retinopathy. And also we can assess the response to anti-VEGF, whether the vessel density is coming back to normal with your anti-VEGF treatment. That is also important. Now, FFA still has a role in diabetic CME because most of the diabetic CMEs are associated with macular ischemia. So you can see the enlargement of foveal avascular zone, you can identify the areas of focal leak, and some patients there will be asymmetry of diabetic macular edema. You will see edema only in one eye. That may be due to a macular BRVO. So FFA still has a role in diabetic CME. Now, how will you differentiate a diabetic CME from pseudophakic CME? So in pseudophakic CME in OCT, the cysts are more in inner nuclear, and there will be usually presence of SRF, and also you will see the hard disk in FFA in the late phase. The other signs of diabetic retinopathy, that like microaneurysm, hard exudates will be seen in diabetic CME, and also more cysts are seen in the outer nuclear layer with disruption of the outer retinal layers. So the treatment, more of nowadays it is more of intravitreal anti-VEGF, not much role of grid lasers, intravitreal steroid implant, and also vitrectomy in recalcitrant diabetic edema. Along with that, you have to control diabetes. The renal function should be assessed, and control of lipid profile is also important. Now BRVO, 30% of BRVO patients will have CME, and here also the mechanism is ischemia causing damage of blood-retinal barrier, treatment by anti-VEGF and steroids. CRVO, hypoxia and inflammation results in breakdown of BRB and macular edema. The most common cause of visual loss in CRVO is due to CME, And in this, if there is associated subretinal fluid, it indicates a bad visual acuity. And OCTA shows more of cyst in superficial capillary plexus in CRVO, but more in deep capillary plexus in BRVO. These are the OCTA findings. Treatment again, you can give intravitreal steroids, anti-VEGF, newer anti-VEGFs, or Sirdex. But even if the macular edema becomes normal, the other factors like metamorphopsia, stereopsis, and contrast sensitivity may not improve even after your injections. CME in CRAO is actually very rare. If it is seen, you should rule out an associated venous occlusion, and also you should rule out choroidal ischemia. Hypertensive retinopathy presents as bilateral CME. It can present in type 4, in grade 4, that is in malignant hypertension. And actually it doesn't need any ocular treatment because it improves with control of hypertension. MACTEL is a disease which can be type 1 or type 2. Type 1 disease behaves like coarse disease. There is increased permeability and leakage, which results in cystoid macular edema. Treatment is PDT and anti-VEGF. While type 2, you can see cystoid spaces in OCT, but it is more of degenerative changes, not fluid accumulation, and you can get disruption of the outer retinal layers like ISOs. Certain vascular tumors, choroidal hemangioma, it can be well circumscribed or diffuse, and usually it is seen 70% occurs in macular area, and it can be associated with cystoid macular edema, and you have to treat it with PDT. Then hemangioblastoma, usually seen in Cohen-Hippolyte disease, and 11 to 50% are juxtapapillary in location, and this can present as cystoid macular edema treated by PDT or intravitreal steroids. Thank you for the